Hello, I'm so glad to be part of this event. It's a great event and great effort that is being done by the Emirates Association for Down Syndrome. Thank you for inviting me again to present in this conference. It's always a pleasure to be a part of events that raise awareness among parents and professionals about the new approaches in rehabilitation of a very important sector of the society, children with Down syndrome. I'd like to introduce myself. My name is Rehab Zaytoun. I'm a medical doctor. I'm specialized in pediatrics. It's a specialty, a medical specialty affiliated to ear, nose, and throat, where the medical entity of speech and language pathology. My passion has always been feeding, oral motor, and feeding and breathing difficulties in children generally, and in Down syndrome specifically. I'm also an instructor for Talk Tools Association in the USA, and I've been involved in raising awareness and spreading the word about oral motor therapy, oral myofunctional therapy, and the importance in developing and maintaining the integrity of breathing, feeding, and speech clarity. I'd like to start the presentation by discussing the myths of Down syndrome population. What are the myths of the Down syndrome population? And I give the credit in this to Sarah Rosenthal Johnson, the person who developed the hierarchy of oral placement therapy, and I would highly recommend visiting the Talk Tools website for free publications and resources about Down syndrome and children with oral motor difficulties generally. So, what are the myths of Down syndrome? When you say the word Down syndrome, or a person or an individual, adult or child with Down syndrome, what are the first things that come to your mind? What is the visual? And visuals are very important in this world. What are the first things that kind of haunts you as a parent once they tell you your child comes with Down syndrome or is carrying this chromosome? You think of big tongue, do you think of mouth breathing, you think of drooling? Many people think of delayed speech development or poor speech clarity, high narrow palate, small nose. These are kind of the features that are linked to the Down syndrome. Actually, the term macroglossia is still present in many of the pediatric references around the world. Why am I bringing this picture to the presentation today? I'm bringing this picture to the presentation today because this is exactly the case of the tongue inside the mouth. And not only the tongue in children with Down syndrome, it's generally the tongue of human beings in their mouth. It's a 6-foot tiger in a 3-foot cage. This is a very important reference for all professionals in the medical field who are minded with breathing and integrity of breathing, sleep apnea, snoring, reflux-related disorders, you name it. Why is this important? Because the posture of our tongue, the integrity of our mouth closure, and the way that we are putting ourselves together while we're breathing, while we're awake or while we're asleep, has a great significance in the development of the shape of our mouth. Let me walk you through this video. Again, visuals are really important, and this video is going to simplify and establish the link between feeding, breathing, and later on speech development, and why muscles are stronger than bones, and muscles do shape the bones. Let's watch this video. I'm going to stop it every now and then to comment and go back to you again to watch the video.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air.
Let me stop the video here and touch or tap on three major points here. Human beings are nasal breathers. We breathe from our nose. We're designed this way. The nose is a natural filter. It's a natural humidifier. The nasal barrier is really important and protects us from respiratory tract infections. Why is this a big issue among the Down syndrome population? It's because of the low tone. One of the key points or the major cause behind so many difficulties. Gravity is pulling us downwards. The jaw is one of the muscles that are affected by gravity. When we are not maintaining proper mouth closure, we are pulled downwards by gravity. If we don't have this strong seal, we're gonna go downward. Think of yourself in your sleep, when you fall asleep in a car or in an airplane, and what happens to your mouth when your mouth gets open involuntarily by the gravity and you start to drool. This is exactly the case with the low muscle tone children when they are not maintaining this good muscle tone and good muscle closure throughout the day. So we have a case of mouth breathing, which turns something that is a natural protection in our body, like the lymphoid tissue in the tonsils and the adenoids, from something that works in our behalf for our best interests into something that works against us. And instead of being lymphoid tissue that acts like a barrier and protection, filtering the air from the harmful things that might cause infection and that might cause respiratory tract infection and breathing difficulties, into an element of occlusion that occludes the nasal cavity and causes mouth breathing. And this takes us to the vicious circle that children have all the time. They have nasal obstruction, they breathe from their mouth. This mouth breathing causes enlargement of the adenoid and the tonsils, so they can't breathe from their nose again. Not only this, but the long-standing effects of mouth breathing will lead to structural difficulties or abnormalities. And we're going to see how did this take place and happen.
Consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per...
Let's stop the video here again and define the other myths of Down syndrome. When you watch this video, they don't have a narrow, high arched palate. They don't have narrow mouth, small jaw. They don't have dental abnormality. These are consequences of the position of the tongue in their mouth. Remember again, This is a 6-foot tiger inside the 3-foot cage. If this muscle is not strong, it's not well used, resting on your palate, it's going to get bigger. Not because it's big, because it's hypotone. Yeah, because of the hypotonia factor that affects the size of the mouth. I keep telling people all the time, it's like having a belly. When you go to the gym, exercise, it's going to decrease in size. You didn't do a surgery to remove it. You didn't decrease it in actual size. You kind of causing it to shrink because you're increasing the muscle fibers versus the content of fat. And the same thing happens for the mouth, for the tongue. But the thing in the mouth, there's a bone and structural factors involved, the palate and the teeth. And this is not always, not only important for the breathing and the dental structures, it's also important for the feeding and the swallowing, because this will lead to the reversed swallow, and people will swallow via contact with the tongue to their teeth. So you'll find yourself with an obligatory mouth breather and obligatory tongue thruster, which means they will move their tongue forward to drink or to swallow, to eat and drink and swallow via a reverse swallow, and they hit their tongue against their teeth to swallow. This is the consequence number one. The consequence number two, they will have to keep their mouth open so they can breathe. And we have to think of how the speech is going to be affected as well. Let's continue with the video, and then we'll discuss the affection of the speech as well.
Per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth and your tongue resting on the floor of your mouth with the tip of the tongue between your front teeth. That is called an open bite, as your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better.
And remember, this is not only among the Down syndrome population. This is a general rule for everyone. And that's why we're using these approaches of oral placement therapy and oral myofunctional therapy with so many people from different diagnoses, because the clinical picture is always the same. Mouth breathing, incorrect swallowing pattern, and incorrect speech production. Our tongue is designed to rest on the palate. When this is not happening, this will lead to incorrect speech production. So you will find yourself familiar with the, instead of da, ta, na. So let's continue with this and see how can this be corrected, and how can we work on improving these difficulties. We simply interfere as early as possible, and we use additional methods to the traditional rehabilitation methods, which is known as oral motor therapy. Oral motor therapy, it's a big umbrella under which goes oral placement therapy, prompt therapy, oral myofunctional therapy, and so many Beckman therapy, and so many other approaches. It's the area of assessment that looks at the normal and abnormal patterns of the lips, tongue, jaw, cheeks, hard palate, soft palate, for eating, drinking, facial expressions, and speech. Why do we need these approaches, and when do we interfere? We interfere since birth. The minute the child is diagnosed, we start to look at their patterns in eating, breathing, and swallowing. With breastfeeding, we do interfere. With correcting the positioning and using the proper utensils for feeding, just to make sure that we do not cause any compensations in the pattern the child is being fed or is being dealt with. We need it, and we need all these approaches, like I've mentioned, with all the clients who do not respond to the traditional therapy and when they need the extra input of the tactile stimuli. Remember that our goals are increasing the awareness of the oral mechanisms, how we move our mouth, the resting tongue posture, how can we incorporate our cheeks and our lips all the time so we maintain the normal musculatures, how we can normalize the oral tactile sensitivity so you do not find children who pocket food for hours, who have food remnants inside their mouth and around their mouth because they can feel their mouth properly to clean it and maintain the integrity of their oral hygiene. You will not find children who refuse toothbrushing and avoid it. You will not find picky eaters or children with food aversions or certain preferences because they can't chew, so they avoid solids because they don't have the muscular ability to chew and they choke on the food when they start swallowing. So definitely the ultimate goal would be improving the feeding skills and improving the speech production and the speech clarity. And remember that the mouth is very rich in sensation. This is the place where you have tactile, taste, and proprioception. When I put a piece of food inside your mouth, you feel its weight, its texture, its taste, and the temperature of this piece of food. So this is an interplay between motor and sensory at its finest status inside the mouth. Let's watch this video again. It's kind of taking us in a journey of development in a child with Down, so for a child with Down syndrome, and how we started with the oral placement therapy and continued to develop into speech. This is the instructor Renee Roy Hill, and this is a person that she started working with early on. She started by training her parents, and the parents started to work with her, and Renee has been seeing them every now and then. The consistency, the dedication, and the modification in the intervention plan created a story of success that I wish to see with each and every child. This is Ella before starting oral placement therapy. Look at her mouth, look at the resting tongue posture. Her mouth is resting on her lower jaw. There is tongue and jaw protrusion. The tongue is kind of attached to the lower lip. This is not the normal. And let's see how she's going to progress with therapy. This is sensory stimulation with different textures. And remember that going inside the child's mouth is kind of very fun or should be very organized. This is a really, it's a really slow process. You cannot just open their mouth and go in there. You have to prepare them. You have to be slow. You have to be graded. It shouldn't be another traumatic experience added to their medical history or their rehabilitation history. Hopefully there are no traumatic experiences in the first place, but it should be very fine steps and very small increments until you get into the child's mouth.
Whoa. I do massage not only with the hand.
This is another important tool that we use with children since the age of 6 months. And instead of the sippy cups and instead of using the bottles that kind of reinforce the suckling pattern, we start using the straws to make sure that there is lip closure, there is tongue retraction, and there is proper mouth development. This is an easy tool that we can use with the children because you can simply compress it and produce the liquid. So you teach them how to suck instead of sucking. Another important tenet that we work on is feeding. We teach the children how to place the food on their back molars so they can chew properly, instead of using their tongue to suckle on the food. I like this part of the video the most because this is total communication. The child is signing what she wants. The mother is helping her with the verbal input. She's signing again that she wants to eat. And now you will see the mother is using the prompt approach to help her to say the word because she's not saying it. And she's been trained in the work on saying the word. This is the prompt therapy for speech production. She's using her hands to prompt the child to use the word eat. So this is another thing that I would like to highlight here. Using total communication is always helpful because communication is not always verbal, and it's not only verbal, it can be signing, it can be gesturing, it can be sign, and we have to work with what we have until we get to the point of verbal communication.
Oh, just and that. Can you say E? Oh, there we go. Eat. Eat. Yeah. That's a silly feeling. Eat. Eat. If I can get under your chin, let's take a look at food.
This is another technique in using spoon feeding. So instead of the tongue protrusion that we see quite often with the children, we're using some support and a special spoon to get her to use her lips to clear the spoon without tongue protrusion. Fun tools like the bubbles to blow bubbles and use her cheeks and lips. Rounding is always important and can be used in therapy. And remember, therapy should be fun, should be play-based, especially in the first 5 years of life. It has to be enjoyable. It has to be something that child is looking forward to, not looking forward to skip. Using the bubbles is not only for the sake of blowing bubbles, it's for the sake of building phonation, the ability to breathe from her nose, get the air going from her mouth, to use it for phonation and proper voice production that will support the speech. And let's see where she got at after years of consistent therapy.
Do you want? Do you want 1 or 2? 4. 4. Good answer. 5. Okay, let's see. Can you count them for me? 1, 2, 3, 4.
I love the way her mouth is moving. Please listen to her speech clarity. Look at her mouth movement. Look at her tongue posture. It's beautiful development that happened across many years, but the result is amazing. And remember, we work across breathing, feeding, and speech. We work with functional skills. It's not blowing for blowing. It's not biting on stuff just for biting. We're using these tools to provide and produce the path for functional skills to emerge and take place over the compensation. We're fighting against the low tone. We're fighting against the gravity, but with consistency, we will get there. Remember, consistency is the key. It's a marathon, not a sprint. So regulate your breathing, regulate your power, try to be as supportive as possible. Eventually, the result and the weight is worthy. When we get to the point of a functional human being who can communicate, breathe, eat, and be independent member in the society, this is worthy of all the efforts that we put in this process. Thank you very much. I'll be with you in the live session to answer all your questions. It's a pleasure to be with you today, and I really enjoyed. Thank you very much.